Good morning. I'm Dr. Vikram Chellakumar, Associate Professor, Department of Ophthalmology from Sree Balaji Medical College. Today's topic for discussion is red eye. Red eye is one of the common conditions that we encounter in clinical practice. And even today, amongst doctors who are not ophthalmologists, once they see a red eye, they always think in terms of conjunctivitis. There is actually more to red eye than just conjunctivitis. And it is mandatory that the students know and how to differentiate between the different conditions of that cause red eye, because there are some potentially blinding conditions which, when not treated appropriately and on time, can lead to blindness. So that is why this red eye has been included in the curriculum, and it is mandatory that students know and how to differentiate between the different causes of red eye. So today I will be talking about the different conditions which cause red eye and how to diagnose them and how to manage them. So the specific learning objectives for today's session will be how to understand the different causes of red eye and how to diagnose them, recognizing the red eye conditions that require urgent referral, and how to manage these conditions appropriately. The final common response to any anterior segment disease is redness of the eye, irrespective of whether the basic cause lies in the conjunctiva, cornea, or anterior uvea. So the eye is basically divided into the anterior segment and posterior segment. Anterior segment, the structures with the lens and anterior to it, namely the cornea, the iris, the conjunctiva, all comprise the anterior segment, and the structures behind the lens, namely the retina, the choroid, the optic nerve, all constitute the posterior segment. So, redness of the eye is basically a response to any anterior segment pathology. If the problem lies in the posterior segment, it usually does not present with red eye. So red eye is not just conjunctivitis. If the cornea is affected, in case of keratitis or in case of uveitis also, the presentation is with red eye. So what are the common symptoms that the patient presents with? In case of conjunctivitis, the patient presents with redness, grittiness, watering and discharge. In case of keratitis, the patient usually presents with pain, photophobia and blurring of vision. And in case of uveitis, again, the patient presents with pain, photophobia and blurring of vision. Whereas in acute angle closure glaucoma, the patient presents with severe intolerable pain and loss of vision. So congestion or the redness of the eye is divided into two types. One is conjunctival congestion and another is circumciliary congestion. In this picture, the eye is divided into four quadrants. If you see the upper outer quadrant, you can see a diffuse pattern of redness. That is conjunctival congestion. Whereas if you see the lower inner quadrant, you can see a type of congestion having a radial pattern to it. That type of congestion is called circumciliary congestion. And there are conditions you can get a mixed type of congestion where you get both conjunctival and circumciliary congestion. Conjunctival disorders usually presents with conjunctival congestion, namely conjunctivitis. Whereas circumciliary congestion is usually seen when disorders of the deeper tissues, where like the episcleritis, scleritis, iritis, disciform keratitis, cyclitis, all these present with circumciliary congestion. And in case of corneal ulcers and corneal disorders, the presentation is usually with mixed type of congestion. Here you can see both conjunctival congestion and circumciliary congestion. Conjunctival congestion has a diffuse pattern to it, and the redness is more marked near the fornix, whereas circumciliary congestion has a radial pattern to it, and the congestion is more marked at the limbus. For the sake of undergraduates, I'd like to note that fornix is the area where the palpebral and bulbar conjunctiva meet. So if you notice redness more in the fornix as compared to the limbus, it is conjunctival congestion. And in case of in the limbus is the area where the cornea and conjunctiva meet. In case of circumciliary congestion, you notice redness more marked at the limbus than compared to the fornix. So how do you differentiate between conjunctival congestion and circumciliary congestion? Conjunctival congestion more marked near the fornix, whereas circumciliary congestion more marked around the limbus. Conjunctival congestion has a centripetal arrangement to it, whereas circumciliary congestion you have a centrifugal arrangement. Conjunctival congestion is bright red in color, whereas circumciliary congestion is purple or dull red in color. Conjunctival congestion, if you look at the blood vessels, they are superficial and branching, whereas in circumciliary congestion, they are deep and usually follow a radial pattern from the limbus. When you move the conjunctiva, in case of conjunctival congestion, the congested vessels move along with the conjunctiva since it is superficial. Whereas in circumciliary congestion, because they are deep, when you try to move the conjunctiva, the vessels do not move with the conjunctiva. This is how you can differentiate conjunctival congestion and circumciliary congestion. So as I told you before, conjunctivitis is one of the common causes of red eye. Conjunctivitis usually presents with congestion, redness, discharge, irritation and itching. In addition to it, there are some other symptoms that are present, signs that are present in the eye. Like the first picture shows a papillary reaction. Papillary reaction usually seen in case of allergic type of conjunctivitis. The second picture shows a follicular reaction. Follicular reaction commonly seen in case of viral conjunctivitis. Next, you can see a mucopurulent discharge that is coming out of the patient's eye that is usually present in case of bacterial conjunctivitis. Here you can see the edema present in the conjunctiva, the lower picture, that is called chemosis, it's called chemosis, and it is usually seen in case of allergic reactions. Next you can see blood in the conjunctival space, that is called subconjunctival hemorrhage, usually seen in case of viral conjunctivitis. And then you can see frank purulent discharge. This is case of bacterial conjunctivitis. The second common cause of red eye is acute anterior uveitis. Acute anterior uveitis patient usually presents with redness, photophobia and decreased vision. The most common is idiopathic. It can also be associated with systemic diseases. Commonly, it is associated with seronegative arthropathies like ankylosing spondylitis, inflammatory bowel disease, psoriatic arthritis, and Reiter's disease. It can also be associated with autoimmune conditions like sarcoidosis and Behçet's, and also infections like tuberculosis, toxoplasmosis, syphilis, HIV, and shingles. So in case of acute iridocyclitis, the upper picture you can see circumciliary congestion. On careful examination in the eye, you can see something which is called a posterior synechia. That is, the iris become adherent to the lens. Slit lamp examination of the cornea can show keratic precipitates which are present on the corneal endothelium, and you can also see flare and cells in the anterior chamber. Sometimes in severe cases, you can see pus in the anterior chamber, which is also called hypopyon. The third condition causing acute angle closure, causing red eye is acute angle closure glaucoma. Patient usually presents with severe pain, loss of vision. Sometimes they also present with headache, nausea, vomiting, redness, and halos around light. Clinical examination, the IOP is very high. The eyeball is stony hard in consistency. Circumciliary congestion is present. Cornea is edematous because of raised intraocular pressure. Anterior chamber is shallow. The IOP is very high in the order of 50 to 100 millimeters of mercury. Semi-dilated, non-reactive and vertically oval pupil is seen. So here you see the picture of a vertically dilated oval pupil which is not reacting to light. The first picture you can see the shallow anterior chamber, and in the other picture you can see edema of the anterior chamber as well as shallow edema of the cornea as well as shallow anterior chamber, which are suggestive of acute angle closure glaucoma. So put it in a nutshell, how do you differentiate between these three conditions? Conjunctivitis, acute anterior uveitis and acute angle closure glaucoma. In case of acute conjunctivitis, the onset is acute. Acute iridocyclitis, the onset is over a few days. Acute angle closure glaucoma, the onset is sudden. Next, the important thing is checking the visual acuity of the patient. Acute conjunctivitis, the vision is not affected because the pathology lies outside the eye, only in the conjunctiva. In acute anterior uveitis, the vision is initially normal but may get reduced over a period of time if left untreated. Whereas in acute angle closure glaucoma, the vision is poor, vision loss occurs. Then you have to give importance to pain. Usually in conjunctivitis, only a mild discomfort or irritation is present, whereas in acute anterior uveitis, patient presents with a significant amount of pain, whereas in acute angle closure glaucoma, the patient presents with severe intolerable pain. Next comes the secretion. In case of conjunctivitis, you get mucopurulent secretion. In anterior uveitis, only watery discharge is seen, whereas in acute angle closure glaucoma, again watering of the eyes can be seen. Then an important key feature is asking a history of photophobia. In case of conjunctivitis, photophobia is not present. In case of acute anterior uveitis, photophobia is the key feature. And in acute angle closure glaucoma, again photophobia is absent. Then examining the type of congestion. Diffuse superficial congestion is seen in case of conjunctivitis. Circumciliary congestion seen in case of acute anterior uveitis, and mixed type of congestion seen in case of acute angle closure glaucoma. The next important key feature is examination of the pupil. The pupil is normal and briskly reacting in case of conjunctivitis, myosed and irregular in case of acute anterior uveitis, and acute angle closure glaucoma is large and vertically oval. Tenderness absent in case of conjunctivitis, present in case of uveitis, and present in case of acute angle closure glaucoma. Depth of the anterior chamber is normal in case of acute conjunctivitis. Normal in case of acute anterior uveitis and shallow in case of acute angle closure glaucoma. IOP is normal in case of acute conjunctivitis. Normal, raised or low in case of acute anterior uveitis, and very high in case of acute angle closure glaucoma. Systemic symptoms absent in case of acute conjunctivitis. Sometimes referred pain can be present. Brow ache can be present in case of acute anterior uveitis. Prostration and vomiting and even abdominal pain can be present in case of acute angle closure glaucoma. Now we'll come to other causes of red eyes apart from these three conditions. The most common is being subconjunctival hemorrhage, where you can see blood in the conjunctival space. It can be diffuse or localized area of blood under the conjunctiva, usually asymptomatic. The common cause being trauma, but it could be also idiopathic or conditions where severe cough is or sneezing are present, patient on blood thinners and hypertension. This is a self-limiting condition which resolves within 10 to 14 days. Next thing is corneal abrasion. Next common condition is corneal abrasion. Corneal abrasion is the condition where the surface epithelium has become sloughed off and it usually stains with fluorescein and commonly follows after trauma. Patient usually presents with pain, foreign body sensation, tearing and redness of the eyes. Corneal abrasions can lead on to corneal ulcer if left untreated. Corneal ulcer is basically because of infection to the cornea. It could be bacterial infection, viral infection, fungal infection, and protozoal infection caused by acanthamoeba, mostly in case of contact lens virus. Mechanical injuries and chemical injuries can also cause corneal ulcer. Alkali injuries are worse than acid injuries. Corneal ulcer usually presents with a mixed type of congestion. This can also be a cause of red eye, and a proper examination of the cornea is very important when it comes to diagnosing red eye. The third most common condition is episcleritis. It is a superficial type of congestion, mostly idiopathic but can also be associated with collagen vascular disorders. Usually asymptomatic, but some mild discomfort or pain can be present. It's a self-limiting condition, but treatment can be instituted with topical NSAIDs and mild steroids. The fourth and the last condition is scleritis, which is inflammation of the sclera. Here it is deeper than episcleritis. If you try to move the conjunctiva, the redness, the blood vessels do not move with the conjunctiva, whereas in case of episcleritis, the blood vessels do move with the conjunctiva. Mostly idiopathic, can be associated with collagen vascular diseases like rheumatoid arthritis, ankylosing spondylitis, systemic lupus erythematosus, vaginous granulomatosis, and polyarthritis nodosa. It can also be associated with herpes zoster infections, sarcoidosis. Usually the patient presents with a dull, deep pain which wakes the patient at night. It's a dull, aching pain is usually present. Systemic treatment with topical NSAIDs or topical steroids along with oral prednisolone can be instituted if conditions are severe. This picture you can see scleritis, where the top picture you can see the diffuse redness that is present in the top two pictures. The third picture you can see dark colored sclera, where it is usually because of scleral thinning. This is called necrotizing scleritis, usually seen in case of rheumatoid arthritis. The three main causes of red eye are acute conjunctivitis, acute iridocyclitis, and acute angle closure glaucoma. So how do we differentiate them? Based on the symptoms, acute conjunctivitis usually presents with redness, irritation or itching, and discharge. Discharge is a key feature of conjunctivitis. Likewise, iridocyclitis presents with redness, pain, and photophobia. Like discharge for conjunctivitis, photophobia is the key feature for iridocyclitis. And acute angle closure glaucoma usually presents with severe pain and loss of vision. So based on the symptoms, when the patient gives you the symptoms itself, you can come to a idea regarding what the diagnosis could be. Then we come to clinical examination. Clinical examination, first note the type of redness. Diffuse redness is seen in case of acute conjunctivitis, and circumciliary congestion is seen in case of acute iridocyclitis, and mixed type of congestion is seen in case of acute angle closure glaucoma. And examination of the cornea, in case of acute conjunctivitis, the cornea is clear and transparent. In acute iridocyclitis also, the cornea is clear and transparent, whereas you notice corneal edema in case of acute angle closure glaucoma. Then we come to examining the pupil, which is a very key part in examination when it comes to examination of the red eye. The pupil is briskly reacting in case of acute conjunctivitis, myosed and sluggishly reacting in case of acute iridocyclitis, vertically oval and mid-dilated and not reacting to light in case of acute angle closure glaucoma. So these are the key points in clinical examination. So if you know, give importance to a proper history taking, that is the symptom with the patient's presence with, and doing an appropriate clinical examination, you can easily diagnose the condition which has caused the red eye and treat them appropriately. When treating, we should be very careful because certain drugs which are indicated in a condition are contraindicated in the other condition. That is why proper clinical examination is very important. Like for example, acute iridocyclitis is treated with atropine to prevent synechiae formation, and whereas atropine is contraindicated in acute angle closure glaucoma. And in acute angle closure glaucoma, pilocarpine is used to break the angle closure attack, whereas it is contraindicated in acute iridocyclitis. So, if you do not examine the patient properly, you can end up making a grave mistake. So, proper clinical examination, proper history taking is very important in diagnosing a red eye and treating it appropriately. So, that brings us to the end of this discussion. Thank you.